So this is very nice to see. We were trying to wear you out the whole day, but it's still the full auditorium. So it means people are really interested in what our speakers have to say. Our next speaker is my good friend and a top researcher, Kristian Thorborg. And he's the father of Hager's outcome score for hip and groin pain. He'll tell us something more about it and something about hip strength measurements.
Thank you very much, Shako. So can everyone hear me now? It's fine? Yeah, thank you. So thank you very much also to Aspetar for this amazing conference, and also for letting me and my co-researchers present some of the work we've been doing in Copenhagen, but also in collaboration here with Aspetar. So this is where we're based, on the top of Europe, at home in Denmark, and we live in Copenhagen, just very close to the airport. So if you ever come by, you can feel free to drop in at any time and discuss other things like groins as well, but we mainly like to discuss groins. So feel free to come by. We don't have the torch in Copenhagen, but on the left there you can see that's actually our new Copenhagen University building, how it's going to look when it's finished. And instead of a flame, we're going to have grass on top instead. So that's going to be very nice. My talk is going to be on patient-reported outcome. And just to define what we're talking about, patient-reported outcome, or PRO, is any report coming directly from patients about a health condition and its treatment. And this talk is mainly going to be about PRO questionnaires, because as you can see, there's a lot of other PROs out there not related to a specific questionnaire, but the questionnaire includes a specific question. It's called an item with a related response, and you can sum that up into a score. And then you can measure how patients or athletes' ability or disability is on a score from, for instance, for 0 to 100. So already in 2010 we published a systematic review on the validity and reliability and responsiveness of these PROs. But back then most of the studies we could include were actually on patients with the hip OA. But what we did find was that the hip outcome score could be recommended for hip arthroscopy, and that was also supported by a later study from the States, and has just recently also been confirmed from a Dutch study. So these studies all come to the same conclusion, that the hip outcome score for hip arthroscopy at the moment can be recommended. But this was in 2010 and the last few years, and you know research is always behind what's being done out there. And these studies were actually only based upon 6 studies, those that related to the hip outcome score, because these patients were a lot younger, and these outcome instruments were not as developed as the ones for the patients with the hip OA. So just in recent years, there's been a few other outcome scores. Hager's is one of them. That's the one I've been a part of developing, but also the IHOT 12 and the IHOT 33 has been developed. And they were included in this study from 2013. So even from 10 to 13, there's been a lot of studies coming out concerning these outcome scores. So we thought it was relevant for this conference to try and find out, again going through a systematic review, which of these patient-reported outcome questionnaires could be used for athletes. And the thing when you do this kind of search is it doesn't help you a lot to put in athletes. So you really have to define it by the age span. So we were looking at PROs for young to middle-aged adults with hip and groin disability. And this was a collaboration with the Dutch and also with the Australians. And to some of you would probably suggest that I might be biased in this kind of study, examining whether the Hager's is working or not. So we brought in 2 Dutch raters, which helped us. So that I was not part of any final decisions on what was rated and in what way. So this study is currently under review, and when you do such reviews, it's not as straightforward as with some of the reviews we've seen earlier. It was also mentioned for the risk factors that there actually is no strict method that has been used for many years. But these are the aspects that we need to look at, so reliability, validity, and responsiveness, and they all have different aspects and dimensions that we have to consider. And just recently, actually from 2012, a system for actually appraising the quality of these studies was published. And they used the consensus standards for the selection of health measurement instrument list, which is also being called the COSMIN. And in the COSMIN, you have 9 criteria, which are used to assess whether a study meets the standard for good methodological quality. And all this has been based upon a consensus meeting, and the scoring and then been developed later on. So for each criterion, it can be rated as excellent, good, fair, or poor, and that is in accordance with the criteria described by Tave, who was also one of the main initiators of this whole COSMIN process. So again, here we see, so one thing is to rate the quality of the study. Another thing is to rate the different measurement properties and to really try and establish how good the measurement properties relating all these issues to reliability, validity, and responsiveness are in these studies. And for that, you use a different scale, and that was also by the Dutch group, where you're rating the measurement properties one by one. And here again, you can score positive, you can be indeterminate, or you can have a negative, and it's not uncommon that you also have no information available on that specific measurement property. So not all studies would have looked at construct validity, not all studies would have looked at agreement. So this was a new systematic review, and these were the questionnaires that we found. So they're based on 20 studies. So quite a lot of studies have come out since the 6 studies from the 2010 regarding this area of research. And what we could see here was that there are 10 different pros, so different questionnaires using, which can be used to assess patients with hip pain, but only one questionnaire which also examines or relates questions to the groin, which is the Hager's that I've been part of the development of. When we then did the methodological quality of these studies, what we could see was these were the main studies where all this methodology was actually covered. So these are the studies and the questionnaires where we can actually say that they have been assessed for the full methodology that needs to be included when you're actually doing these studies. So it's not combined by, these are combined by several studies, so not just by one study, but by several studies, the methodology was covered. That also means that the rest of these questionnaires have not been sufficiently covered by this methodology, and that actually means that it's uncertain for us to say how good the quality of these studies are. So, and again, to try to say something about the quality of these studies, when you use some of the other measurement scales that we've seen, then you actually come up with one number, or you get 16 out of 20 for a full study. But here you actually have all these different aspects that you have to consider, and it doesn't multiply into one number. So what we did instead was to look at how many poor methodology ratings do you actually get in these studies. And there you can see that even though these were the studies where everything was covered, you still get 23 of poor methodology ratings in the Hager studies. In the HOS studies, so the hip outcome score, the one that was recommended, you see that they actually have quite a lot more poor methodology in their studies. And also you can see the IHOT 33 is up there, while the IHOT 12 seems to have less poor methodology in it. So this is just to describe it. We're not making any conclusions, but just to bring it out before you make the decision on what kind of questionnaires you want, and also based on the quality of the studies that they've been measured in. So when we then use the criteria list, and remember you had all these 8 aspects, relevant aspects, then we could see that when you look at the Hager's, the IHOT 33 and the 12, they received the best ratings by receiving 6 positive scores out of 8 relevant scores. And then the HOS followed with 5, so very close. And this is more concerning the measurement properties. So they've been looking at 5 out of 8 properties in the HOS, and they've been looking at all of them, but they've had adequate scores for 5 out of 8. And then again, the measures that where we don't have full methodology quality in the studies are also those where you have less positive scores out of the 8 relevant scores. And again, here you have the HOS, which was never developed for athletes, but more for patients with hip OA. And you also have the modified Harris hip score that I'm sure most of you know, because that's probably the most extensively used for hip arthroscopy. And also the non-arthritic hip score is one that keeps coming up in the literature, but actually has not been sufficiently addressed scientifically. And then you have a few scores or a few questionnaires that haven't been addressed sufficiently there in the bottom. So what you have to do is look on the top here. These are the one that we recommend at the moment, and that's also the conclusion. So we recommend that for young to middle-aged patients, these are the questionnaires that you should consider using. Not all of them, but you also have to look in because they do have different measurement aspects and different measurement scales. So there might be some that are more relevant for hip arthroscopy than for your athletes with adductor-related pain. And again, that's probably more for you to consider when you design your study and when you look at the questions. Are these questions relevant for my population that I'm going to measure this in? And then you can say that Hager's is the only pro that is aimed for young to middle-aged adults, including athletes, that actually presents with groin pain. So it's the only questionnaire which actually relates questions asking about, specifically asking about pain in the groin. So if you look at the conclusion, there are quite a lot of studies, and I'm part of this because I think we've been too focused on then addressing which is the most useful pro at the moment. And this is just, I've just taken this as a headline for a paper that was only on test-retest reliability. So they're trying to say what's the most useful one when they only looked at one aspect of 8 to 9 aspects. And again, I'll just say that it's way too early to say this. So that's the main conclusion. We cannot say which one is the best one, but we can say there are 4 out there that has passed the methodological quality and also has good measurement properties at the moment. So on the Hager's, so the main thing for this also so we can advance is to get as much data in as possible. We need high numbers. Also, if we want to do a more advanced statistics, such as could be item response theory, where you're looking at RAS analysis. There's going to be a talk on that later, but you really need high numbers. You want some heterogeneity in that. There could be cultural, that could be between age groups, sports like that, before you start to apply this, because otherwise that model will just not, it doesn't make a lot of sense to try and fit it to that model. And the web address in the bottom is where you can find information. It's now been translated into Swedish, Norwegian, English, Dutch, even a Qatar one now, and there's also a French one which very recently is on this website. And these are free access, doesn't cost anything. I don't get rich when you use them, I just get happy. So thank you very much. That was the end of my first talk, and I'm just going to skip to my second talk. The second talk here is more on hip muscle function and strength testing. And again, just very happy to be here. And this is one of the most beautiful pamphlet pictures I've ever seen of one of my future or of my PhD student, but also a student I had as a bachelor student, and this was the conference last year where they did the strength measurements. I did a talk on strength measurements. So many different hip adduction strength tests exist today, and you can see some of the different possibilities. You've already seen them in some of the talks. And basically, when I did my PhD, one of the tasks I was given by my supervisor, Per Hölmig, was to come up with a better assessment method than what he was using in his clinic at the moment, because you can see that his system was that he tried to classify people into whether they were weak, intermediate, or strong. And he was actually quite good at doing this when he compared to himself. But as soon as he asked somebody else, you can see the intertester value, they just didn't agree with him. So we had to come up with a different system for this, and something that was probably a bit more objective than the old system and more sensitive to some of these smaller changes happening in these athletes. This is the other system that I've been taught when I went to get my physio degree, and that has no relevance in lots of these athletes because they will come in with a 5, so normal strength, and they will of course have no chance of improving that. So again, not sensitive. So even though they might have a big strength deficit, and that's been shown in some really old studies that you can actually have a strength deficit of up to 50%, and this will still be missed by this system. So this is not a very good and certainly not a sensitive system to measure strength in. So that was not part of our consideration for moving on. Instead, we considered whether we should use isokinetic testing, but we could also see from the literature, and was also very nicely pointed out by Andrea today, that there's quite a lot of studies using handheld dynamometry, and actually Tim Tyler was one of the first ones also to apply this in an athletic population and do research on it. So that was actually what gave us the idea to see if we could use this in a more clinical setting. So having handheld dynamometry, you can do isometric testing, and you can also do eccentric testing, whereas concentric, you would really need that isokinetic device. So basically, I'm mainly going to talk about these two testing methods. Again, just the study that's been referred to earlier on, and how they actually, with the handheld dynamometer and using the adduction to abduction ratio, could show that if you had an AD adduction to AB adduction ratio below 0.8, that would increase your hip adductor strain injury risk by 17 times. So a dramatic increase, although we have to consider this was still a small study that has never been replicated. Also by the Norwegians, they also showed that muscle strength may be of real importance in predicting future groin injuries, and they showed that was actually the biggest risk factor in this multivariate analysis, where they just divided people again into weak or not weak, and it comes up as a 4 times increased risk of getting a future injury. My talk is not going to be on that type of strengthening, as I said, because I think when you're doing strengthening, you really want to make sure that you get unilateral strength values, whereas as soon as you do the more squeeze type of testings, you will have a contribution from both sides. And I'm not saying it's not of any value, I'm just saying it's not pure strength from one extremity or the other. It's just a combination, and that will always be decided by the weaker leg. So the purpose of this was to be able to come up with something that gave us an idea of the force contribution from one side. We would then be able to compare sides just as Tim did. We would be able to make ratios as Tim did, and we would be able to adjust for the lever arm, but also relate this to their body weight, because that's one of the other things, is that there is a huge variation in strength among you guys in here as well. So to compare, we really have to relate this to mass, so the body weight, and also to the length of the lever acting on this strength measure. So I think that was one of the main reasons why we came up with using the handheld dynamometry. And we came up with, especially we did a lot of different, we have for all movement directions, but these are probably the main one we use for groin injuries or for predicting groin injuries, trying to at least. It's the isometric one, which has substantial test-retest reliability, and has a high ICC, and there's no systematic variation. And again, the systematic variation is very important to consider, because a lot of strength measures, if you just measure people twice, already on the second measure they will be stronger, just because they've now learned what this sort of exercise is actually, what we're trying to do with them, so they can increase by 10, 20, 30% just by giving them a second practice. And we also thought that it would be important to have a more eccentric test, and something that would stress the muscle tendinous junction and insertion point more. So we came up with this sideline. Again, we were using this as a break test, so it's different from just the isometric one. And again, by 1 or 2 years practice and developing this, we came up with a system where we actually could get students to get good values, but that was much more difficult to do. And here again you see the variation between test and retest is around 7%, and that means if you do not, if your patient or your athlete do not improve by or decrease by more or less than 70%, this improvement of 6% could just be measurement noise, really. So these are some of the several publications that we have done, so 13 or even more, just on the methodology part of it, because we need to know that our measures are good so we can actually trust what we're doing. And I would say these are the main points that you have to consider when you're using handheld dynamometry. A long lever is almost always better than a short lever, and it's just because you can produce less force, so it's easier for the tester to resist and not being pushed away. It's important that you eliminate the learning effect, and there is quite a lot of learning effects, so sometimes you need to do 3 or 4 measures before you can be considered that they actually plateaued and they're not just improving by doing number 4 or number 5. Positioning of the subject is so important. I will show you some of the differences you can see if you don't get that right, and stabilization is part of that. And then, of course, if you want to take this to the field, you need to consider intra and inter-tester reliability with that. So here's the positioning which can cause problems. So here I'm just comparing a study from Australia, which is a brilliant study, but where they're actually doing a similar measurement, and you can say similar position of the leg. One, they're lying on the side, on the left there, with no fixation with hands. The other one, in our study, they're lying on the stomach, and they are allowed to fixate with the hands. And here you can just see the difference in force output on a similar population. So it's almost a factor 10, or it's more than a factor 10 in force output, just because you have a different position. And again, here is one where you're allowed to stabilize or fixate on the right with your hands in our setting. And here's one where you're actually asking people to put their arms across so they cannot stabilize. And again, you get a factor 4 just in the force output, or the torque really, for these two. I normalized it to torque because that was the information I could get from these studies where they were comparable. So again, just means that it's a completely different test and a completely different challenge also to get the strength value. And then, of course, the issue of inter-tester reliability and the beautiful data you saw from Andrea Mosler this morning here from Aspetar. When they're doing the screening, she cannot do 345 screens for muscle strength. She needs to get a lot of testers in, so we need to know that these measures are actually working. And we were, together with others, have showed that gender and strength for the tester is a real problem when you do these handheld measures. And we also showed that you can eliminate that by having a fixed setup where you're actually using a belt. But now it's no longer handheld. Now it's almost like an isometric, isokinetic device. So it's not as useful when you have a big cohort. It takes longer. So we tested that down here, and Andrea has some data where she can show that it's actually inter-tester reliable as well. But you also just have to know that as soon as you go to several testers, you will have more measurement variation. So that will work. If you have a bigger population, that could be okay, but especially in a small cohort, it could be really problematic because you have more measurement variation. And we've used these tests. So this is the eccentric test for abduction. And again, these were for patients who had external snapping hip. But again, this is just to show some of the importance, I think, of having an isometric and an eccentric test, because when you look at this data, I'll see if I can get this. This is in eccentric hip abduction. That was the only test coming out where they actually had a deficit. That means as soon as we put the isometric measures on these patients, there is no deficit when you compare those to a control group. So I think it's really important to have a test where you stress these athletes or young patients to a higher degree than just providing an isometric test. If you have a more of a surgical setup where you have a lot of strength deficit, isometric will work fine. You can find isometric deficits around 25 to 30%, no problem. We also, a very similar model to the one that we have now applied with Andrea down here. We've had, these are 800 novice runners where they actually done this eccentric hip abduction. And again, just to point out that we then get some information on where those with low strength and high strength are. And again, that is relevant in relation to the type of injury that they might get, not only in the hip, but also maybe in the lower extremity. And you can see here that the males are stronger than the females, but you can also see that there's an age trend here. So these are things you have to consider and put in the model when you actually do the measurements. Then we applied this eccentric strength for the adductors to soccer players in Denmark. And we also had a control group. And I think the main thing with this study is that we decided to make it assessor blinded. So when Andrea presented a lot of her studies in those cross-sectional studies, I think one of my main issues is that they're not using blinded testers in all these studies. So if you know what group these people are already in, that might influence the way that you will measure these people. So I was the one doing the measurements here, but I was blinded to whether this was a patient or a control. And these patients and controls, or not patients, they were actually just soccer players with adductor-related groin pain that came in, and a lot of them were actually playing, but they were matched to other soccer players playing in the same clubs at the same level. And what we could see here again was that when you then look at the isometric tests, and you also divide that into dominant and non-dominant leg, there is no difference between the controls of those with groin pain, adductor-related groin pain. But then when you use the eccentric test, we actually found an eccentric deficit of 20%. So again, I think that was a bit surprising to us, but the main explanation might be that more than around 70% of these players coming in with problems that they were just persuaded to come into the study if they felt like it, and they were playing soccer. 70% was actually actively playing. So I think for these athletes, you need a much more stressful test to be able to pick out these deficits. And again, just to comment, and that's the same model we're using down here, and Andrea Mosler's PhD student within the center, and I've been so lucky to be part of the supervision for her. And again, this is just the similar way of looking at her data, where you can see the 1 and 2 standard deviations. And of course, we're especially interested in those data below the -1 standard deviation, so the low strength values, because that's what's been referred to in the literature as something that could predict groin injuries. So that will fit nicely into that theory. Again, there's also the abdominals. So why don't you measure the abdominals? That's much more difficult with a handheld dynamometer. And there is actually a nice study where they're using this isokinetic machine. Interestingly, they find a very similar thing when you look at the concentric contraction, because you can do that isokinetically. No deficit between people with groin pain and controls, matched controls. But again, if you then look at eccentric abdominal strength, again, it's a similar pattern that you get a deficit of almost 40% reduction in those athletes with groin pain. So again, I think it's a measure that's truly relevant. It's just much more expensive equipment and things that you could do, and probably things we need to do down here in Aspetar as well. So how can you use these measures also for your management? This was an acute adductor injury we got in, and actually it's a full rupture, and he had it on one side, and then a few years later, I think it was 1.5 years later, he actually got it on the other side. The interesting thing was that he had similar mechanism of injury, and in this case it was not as Andreas described. He was not part of the 60% who had it on the kicking leg. He actually had it on the standing leg in a position like the guy on the right. So remember, Andreas also said that 40% would be on that side. And when you looked at the ultrasound after 2 weeks, because in Denmark we cannot get these guys within 2 days or 3 days like here at Aspetar, they had very similar ultrasonographic findings, and the specialist who's done a lot of these said these are very, very similar injuries. But when you look at the recovery of the muscle strength, the second injury that looked exactly the same as the first actually took 10 days to normalize the strength, whereas the first injury took up to a year before you actually normalize. So sometimes we even think we see the same degree of injury, they might have completely different strength recovery rates, and that's also why I think it's very, very important to measure these things, because they also might tell you something about the prognosis that we cannot just have from the ultrasonographic or MRI in itself. And as you can see, these with the 2 injuries, what you can see here in the bottom, we just used full training session, because being selected for a match is just a lot of other things that relates to. So we just wanted to know when this guy was in full training, and it took 15 weeks for the first one, so a little longer, but 12 weeks for the other one. And if you relate that to the literature, and this might be crazy Americans, but still this is when you look at the American football, they would be back in 6 weeks for the exact same injury when you don't operate on them. And look at the range there. Some will be back in 3 weeks, and some will be in 12 weeks. So these are just, I think they're probably not really ready to be back, but they are back. So they are on the field playing with these only 3 weeks after a full rupture of the adductor longus. And if you remember our data, you could see that after 10 weeks, so if you look here, he returned after 12 to 15 weeks, and you can see that's probably fine on the second injury, but on the first injury, he still got a 20% deficit. So this is the same approach as we're trying to apply down here, and you saw this is the other PhD student that we're supervising and doing a great job at Aspetar again. Here he showed you with the 110 males, and he also showed that a lot of these injuries and the acute ones are actually adductor injuries. And we have an ongoing inclusion with Andreas, and he's looking at the criteria-based return to play that Aspetar has initiated down here. And it's going to be very interesting to see how fast they can get them back, but also how these specific measures are actually looking at these time when they come back. So last year I was asked to, or it's actually this year it came out, but last year after the conference we were asked to do talks, and in this journal we had a theory on how you could use these measures, and you could use the isometric testing actually from the beginning. That's what we did in the other study, and then you could introduce eccentric testing when you had an isometric adductor to abductor ratio of 80% maybe. But this is a theoretical model, and you might have to consider a lot of things. So basically what I think Andreas will be able to do is come up with specific criteria, but also more knowledge into how this model should actually look in real life, and not just me suggesting some common knowledge at this stage. So thank you very much.